I would now ask for our second speaker, Dr. Ida Safitri, pediatrician from Gajah Mada University, and she will present about fluid and monitoring, the primary modality of dengue case management. Please, Dr. Ida Safitri.
Thank you, Prof. Utarini. Good afternoon, good morning, and good evening, professors, doctors, and also colleagues. First of all, I would also like to express my gratitude to the organizers, and it is an honor for me to be here and join this dengue forum. In this occasion, my talk will be more focused on clinical aspect of dengue management, and it is about fluid and monitoring as the primary modality of dengue management. So I will start with a global situation and national burden of dengue, and also the strategy to control dengue. And I will also a bit talking about pathogenesis, diagnosis, classification, and treatment, and of course, fluid management. WHO estimate that around 3.9 billion people are now living in area where dengue is transmitted. And those include 129 countries, mostly are in Asia. And around 390 million dengue infections occur yearly, and about a quarter of them are manifest clinically. This is the data in 2017 that dengue affected and distributed equally among female and male. And the data also show that Indonesia is in the third place after Barbados and Republic Dominica. Dr. Tejo said that Indonesia is in the second place after Brazil. I hope that data is older, so it means that we are now getting better. We are talking about the global and national strategy to control dengue. WHO has been launched a roadmap for neglected tropical disease 2021-2030 because dengue is considered as one of the neglected tropical disease, and we can see that the target for control dengue is a case fatality rate due to dengue would be 0% by 2030. And there are fundamental critical action to achieve this goal. Three of them are: first, continue developing preventive vaccines for all at-risk population, and then further develop evidence on effective vector control strategy, and also continue collaborating with environmental sectors and engineers to reduce mosquito habitats. In the left chart is the data about incidence rate and case fatality in Indonesia. So over 50 years period dengue existed in Indonesia, we can see that the incident rate still up and down. However, the case fatality rate could be maintained below 1% for the last several years. And our government also already put dengue control strategy in Indonesia's National Medium-Term Development Plan, or RPJMN 2020-2024. Dengue is listed as the potential disease-causing outbreak, and it was discussed in the strategy for improving disease control. And one of the target by 2024 is 90% of districts and cities in Indonesia have incidence rate below 49 per 100,000 populations. And to achieve this strategy, we need national strategy for dengue control to be developed. I would back shortly to the immunopathogenesis of dengue infections. Primary exposure to dengue virus will induce both humoral and cellular mediated immune responses. And during a secondary infection with a different dengue virus serotype, cross-reactive, non-neutralizing antibody will bind to virus and enhance viral uptake via Fc gamma receptor, resulting in enhanced viral replication and also higher antigen load. Dengue virus itself may have a direct effect to endothelial cells. Inflammatory mediators that released by T cells and by virus-infected cells, along with the complement activation and immune complexes, may result in enhanced vascular permeability and also coagulopathy. So we can summarize that the two major pathophysiology of severe dengue infection are plasma leakage leading to hypovolemic shock and bleeding leading to hemorrhage. So if we see this condition, that's why the fluid management then becoming very important. And this is the clinical course of dengue infections. So the disease will start with the febrile phase and then followed by critical phase and ended with recovery phase. During the febrile phase, it is usually lasting 1 until 3 days, characterized by increasing of temperature, and it is also the same time when the viremia is increasing to the peak. And during the critical period, which is last 24 to 48 hours, there is a potential clinical issues happens, such as shock due to severe plasma leakage, bleeding, or severe organ impairment. And during this critical period, we can also see that there is a laboratory changes where the hematocrit is increasing together with decreasing of platelet count. So the major manifestation changes in dengue need to be observed carefully. All the signs and symptoms which appear at different phases. So in the febrile phase, among children, we should be careful about the potential complications such as dehydrations and also convulsion due to high fever. And in the critical periods, the potential complications usually occur because there is severe plasma leakage or maybe bleeding or organ involvement. And the absorption phase, we also need to observe whether any potential complication like intravascular fluid overloads due to continue or aggressive volume resuscitation during the convalescence period. This is the WHO dengue class classifications. We know that there are 1997, 2009, and 2011. Some countries are using 2009 guideline, and also some countries still use 2011 guideline, like in Indonesia. However, Indonesian Paediatric Society had been introduced and disseminated, and currently we are working to finalize our national dengue clinical guideline using the WHO 2009 guideline. So what is the best management for dengue? At the moment, there is no specific therapy is available for symptomatic dengue infections. Effective treatments still relies on good supportive care, in particular emphasis on fluid therapy and also management of bleeding complication. This is the algorithm. So if we have a patient presented to the clinic, then we need to decide whether the patient could be presumptive as a dengue, especially when there is a sign and symptom of fever with those two of these following criteria. And we need also to see whether any warning signs appear, so abdominal pain or tenderness, persistent vomiting, mucosal bleeding, liver enlargement, or there is evidence that there is increasing of hematocrit with concurrent with rapid decrease in platelet count. If there is no warning signs appear, then the patient should be considered ambulatory and can be managed at home with educations. And we classified into group A management. Those presented with warning signs need to be observed in hospital, and we also need to see whether any coexisting conditions such as maybe infancy or, for example, overweight or there are any social circumstances that need to be observed carefully. And those presented with sign of severe dengue, severe plasma leakage or severe bleeding, severe organ impairment, need to be hospitalized, maybe in high dependency care unit or in pediatric intensive care unit. For those who present with compensated shock, we should immediately start the isotonic crystalloid administration, and then observe after the resuscitation whether any improvement on the hemodynamic. And then also we need to check the hematocrit levels, the urine output, and crystalloid solution should be, the rate of infusion should be decreased gradually and stop after 48 hours. Those who are not improved by resuscitations, the hemodynamic is not stable. If the hematocrit is still high or increased, then maybe there is the place to give a second bolus, or maybe we can use also another solution such as a colloid. And those with unstable hemodynamic, but the hematocrit tend to be decreased, maybe we need to consider whether any bleeding, severe or maybe occurred bleeding, then the transfusion needs to be considered. Those with hypotensive shock, we need more aggressive crystalloid solution. So a large amount of crystalloid solution should be given as soon as possible. And again, after resuscitation, we need to observe whether any improvement in the hemodynamic, the urine output, and then monitor the hematocrit, whether we can start to reduce the infusion rate and then stop after 48 hours. Similarly, with those who are not improved after resuscitation, we need also to check the hemodynamic and also the trend of hematocrit, whether increase or decreasing of hematocrit, and monitoring the oxygen, the heart rate, blood pressure, level of consciousness, temperature, and of course the urine output. So there are evidence about fluids management for dengue. From previous randomized control trial, I think in Vietnam, there are 3 randomized control trial comparing crystalloid versus colloid and dengue shock management. It can be concluded that in DSS, it can be treated successfully with isotonic crystalloid solutions. And if a colloid is considered necessary, the clinician must continue to rely on personal experience, also the familiarity with particular products, and also the availability in the health facility, and of course, the cost also. And the optimal choice for colloid solutions, a medium molecular weight preparation that combine good initial plasma volume support with good intravascular persistence. And they're also acceptably tolerability. We can say that the 2 main types of volume expander used to replace lost fluid in the management of dengue are isotonic crystalloid solution and also colloid solution. Of course, each solution have their strength and also weakness. For crystalloid solution, for example, a normal saline or ringer lactate, it can be used as initial fluid for volume replacement in the management of shock, and it can be distributed throughout the extracellular space, and we have to be careful. Maybe we need to reassess after every fluid bolus is being critical. For the colloid solution, such as albumin or phosphorus plasma, should be reserved for patients only who presented with profound shock or those who do not have a response to initial crystalloid treatment. It is usually less widely available and also takes time to prepare. Blood-derived colloid solution may cause sensitivity reaction. Synthetic colloid also may cause coagulopathy. If usually they already achieve the maximal used within 24 hours. This is a review. It is published currently in 2020. Also mentioned about the 3 solutions that used in dengue. So isotonic crystalloid solutions, human-derived colloid solutions such as rasposon plasma or albumin, or synthetic such as dextran, gelatin, or stat that we use in our clinic. So we need to see the characteristic of each solution. For example, like isotonic, it is rapid distribution throughout the extracellular fluid that have effect on small hematocrit dilutions compared to a colloid where they have a large molecular penetrate to endothelial glycocalyx layers slowly, but also have a greater initial hematocrit dilution effect. Isotonic may make plasma oncotic pressure fall, while colloid make plasma oncotic pressure rises. And both isotonic and colloid solution, so far there is no difference in terms of expected effect in profound shock. And there is no evidence whether crystalloid solution have potential to restore the function of endothelial glycocalyx layer. But for colloid, both human-derived colloid and synthetic have effect on intravascular volume dynamics. This is a publication from Bangkok, from Queen Sirikit International Institute of Childhood. So they show their experience so far in managing dengue cases. The data showed that since 2008 until 2015, overall CFR is around 1 to 5%. For those who work in patient, the CFR is lower, around 0.1%. Interesting that they experience that put the list of problems and also the list of solutions will be very helpful to reduce the CFR in dengue. So the problems could be improper or delay on diagnosis, maybe delay on recognition of plasma leakage or severe dengue, or maybe improper in recognition of bleeding, and the solution is in the right sites. So early diagnosis, including rapid using where available, using rapid diagnostic, it's very important, and also education of outpatient, then optimal fluid management of plasma leakage, maintain high species of bleeding, those in severe cases, and optimal transfusion practice, early recognition of severe dengue, and also educate the patient about warning signs to avoid prolonged shocks. This is another study in Sri Lanka, also show us that the need or the requirement of fluid could be different between dengue fever and dengue hemorrhagic fever, where the HF needs more fluid rather than dengue fever. And this is another study conducted in Malaysia by Prof. Lisindum. I think she also joined this meeting. This is a pilot study. This is randomized controlled study in primary care. It's about 2 months, involving 143 subjects. The inclusion criteria is a patient aged more than 12 years with suspected dengue fever, with thrombocytopenia less than 150,000. And the intervention group will receive a flu chart and also cup. Those the control group, the intervention group is flu chart and cup, and the control group dengue home care. So the main outcome is to see the hospitalization rate, the IV fluid requirement, and also the total oral fluid intake. And the results showing that even though there is no statistically significant difference between these two groups, intervention and control group, but fewer patients in intervention group required IV fluid, and they also increased amount of daily oral fluid in intervention group. The conclusion is that the fluid chart maybe could be implemented because it is a simple, inexpensive tool, may reduce hospitalization and intravenous fluid requirement in suspected dengue patient. Of course, there's also suggestion that the study needs to be enlarged to greater populations. When blood transfusion should be administered, because besides plasma leakage, the bleeding, also the other issues in dengue management. Blood transfusion can be life-saving for patients with severe bleeding that compromises cardiovascular function. But of course, it should be undertaken with care because the risk of overload. And platelet concentrate, fast-frozen plasma, and also cryoprecipitate may also be needed, depend on the coagulation profile. At present, there is no evidence that prophylactic platelet transfusion have any value, and it should be, or to avoid just to increase the platelet counts. Yeah. Studies in pediatric patients of dengue shock syndrome have also shown no benefit of prophylactic platelet and FFP transfusions. So these are two publications about guidelines for transfusion in dengue. So even though WHO recommended to give whole blood, but recently we are strongly encouraged to use blood component instead of whole blood. So packed red cell or platelet or fast-frozen plasma. Platelets are indicated only in severe bleeding. Even if there is a bleeding, consider packed cell first. And platelet transfusion indicated for those with platelet count less than 50,000 with, again, severe bleeding or unstable hemodynamic, or maybe invasive procedure is planned, and indicated for those with platelet count less than 20,000 with, again, severe bleeding or unstable hemodynamic, for example, with shock or other associated risk factors. And maybe could be also give to a patient with platelet count less than 5,000 with minor bleeding. So the other issues is about corticosteroid treatment. Do we need the corticosteroid? There is a systematic review. The study was including 23 trial where the corticosteroid was given in preliminary stage, in intermediate stage, and also in the late stage of dengue. The result and the conclusion is varied because there are, in other study, there is some benefit of corticosteroid, but in other studies, there is no benefit of corticosteroid. But in conclusion, from this review, that it is highly unlikely that the use of corticosteroid in dengue treatment result or have effect in viremia or any other significant adverse effect or complication. But the effectiveness of corticosteroid in dengue depends upon the sustained and maintained therapeutic blood level of corticosteroids, yeah? And also the adequate durations of using steroids. So this is my last slide. So understanding the burden of disease, the pathogenesis, and also the natural cause of disease of dengue is fundamental for the clinician who dealing with dengue patients in order to achieve the target of dengue control program, which is we would like to reduce case fatality rates until 0% by 2030. And in the absence of antiviral, yesterday we also listened about antiviral developments, then currently we still rely on fluid management, and it should be implemented thoroughly. The evidence also showed that by close monitoring with adequate fluid management can reduce hospitalization, and also save the lives of dengue patients. Thank you very much, Prof. Adi.